out. We're an energetic bunch this afternoon. Good afternoon. Hey, we're really glad you guys are here today. We had the first session today at 11 o'clock, and we got absolutely wonderful response. And I hope some of you are here because some of your colleagues told you what a great session it was. We're happy today to have Dr. Nezami with us. He's going to talk about a range of treatment options, different than maybe what we're used to hearing about, to help better prepare you in the unfortunate case that you or a loved one were to be diagnosed with cancer. It's to help you be better informed so that you can make the decisions for yourself and your family that you need to make. Dr. Nezami is board certified. He's a graduate from USC. He trained in integrative cancer therapies. He's been in practice 17 years. He's currently the director of Pacific Medical Center of Hope in Fresno. He's a national researcher and speaker. So this is the rich and famous today, right? His main areas of focus have been integrative oncology and also immunology. Dr. Nezami, the good news is, has proven success with Parker team members. You're going to hear a little bit about that today. Of course, we don't share names because we wouldn't do that from a protection standpoint, but you are going to hear about some of the successes he's had. You know that Parker's leadership is dedicated to helping provide you information that better prepares you so that you have the decisions the information that you need to make your decisions. So the first session, I think what you'll find with Dr. Nezami, and I had to wait until after the first one, he's personable, he's entertaining, and in my words, he's real. So would you please join me in welcoming Dr. Nezami.
Thank you very much. Thank you. Wow, I didn't know I have all these qualities. Okay, so let me first introduce myself a little bit more in the sense that how I became a cancer specialist in the field of integrative therapies. I practiced medicine for about 15 years conventionally before I was even interested in integrative medicine. In fact, when I was a resident and even during my fellowship, when a doctor, a student, a medical student, or another resident or intern talked about any natural therapies, I was just turning them off. Because I was such a hardcore resident that I was just into what book says, what the research is done. I don't accept any natural alternative therapies. And so I don't come from an alternative medicine background. Because you see a lot of naturopath doctors and you see a lot of chiropractors and other doctors that are starting with natural therapies as their career. Mine was different. Mine was just all about what conventional medicine says. If you have cancer, you need to do chemotherapy. That's it. And then what happened was that after about 15 years, I started to look back. Because what happened was that I found that there are pitfalls, there are problems, there are challenges in the world of conventional medicine, and sometimes even corruption, especially in the field of cancer. And so just keep that in mind that I have been trained in both worlds, both alternative medicine and conventional medicine, and I'm coming with a full faith in conventional medicine. And even to this point, when I see some patients coming and bringing me some supplements and natural supplement stuff that I'm not familiar with, I tell them don't take it. I'm very against something that is not scientifically proven. I'm all for science, and what science proves to be effective, I'm all for it. And it doesn't matter if it's chemotherapy, if it's radiation, or if it's natural therapy. If it works and it's, in your case, effective, I will use it. But that said, I'm very hesitant to blindly prescribe or recommend chemotherapy for patients without considering the toxicity and without considering the fact that most of these chemotherapies, as you see, are very harmful, not only for the body immune system and the whole quality of life, but also they make the cancer more resistant and more aggressive. What I explained earlier to the group was that we try to blame whatever happens to us. So for example, if somebody's cancer grows and it is advanced, we blame either ourselves or we blame the nature of the disease or we blame the genetic. The reality is that majority of the cases with advanced disease, we have to blame the therapies that we have used, because those conventional therapies, chemotherapy, radiation especially, they can make the cancer more aggressive. And we'll talk about that. I actually got an email from my cousin that I had never seen since I was 2 years old. She called me, she's a scientist at Dana-Farber just a few months ago, and she said, you know, I looked up a research and I came up with your name. And I said, this name is familiar. So I remembered I saw you last when you were 2 years old. and she's doing the research in Dana-Farber on radiation therapy being proven and published, the literature, that radiation therapy can make cancer stem cells more angry. And the same is true for chemotherapy. So we'll talk about that. And then I got involved during the process of conversion from conventional, totally conventional therapy to using natural elements. It was a big process that evolved through time. It took me about 10 years to be able to find what therapies work and what therapies don't, and customize those therapies to special tumors. So I gave an example last time in this session. I said, well, if you have a lump in your breast, or if you have a tumor in the brain, or if you have a lung cancer, we as the oncologists, we as physicians, we treat them based on the location of the tumor. So if you go to the oncologist, they say, oh, you have a tumor in your colon, or if you have a tumor in your breast, so we treat it based on the location of the tumor. And it's the same all across the board. So it doesn't matter if we have 5 or 10 people in this room that they have breast cancer, the treatment is the same, which is outdated. In fact, I can show you that everybody's tumor, every breast tumor, every lung cancer, every prostate cancer is different. And they behave differently. And because of that, the treatment has to be customized. Both conventional and natural therapies has to be customized based on the genetics of that specific type of a tumor. So in the last 3 or 4 years, my job has to be more acting like a detective, trying to identify what therapies work on specific genes. And the reason that I got interested was because I told the folks, I was a terrible student in biology. And I never imagined becoming a doctor. In fact, what happened was that I was great in physics and math, and I could see myself as an engineer. And biology, I didn't have a clue, because everything was memorizing, nothing made sense. But the fact was that where I was going to school, if you're a good student, which I was a top student, you have to become a doctor. And so even my physics teacher was telling me, okay, you're going to become a doctor, right? And that's why when I practice medicine, I practice it differently than other doctors, is because I'm using my engineering mind. And that's how I assemble the therapies based on the genetics in the DNA. Well, you see in a few minutes how that works. So a brief introduction, I do a lot of research. I'm getting together a protocol to approach the Food and Drug Administration and National Cancer Institute, which I was in a few months ago in, talking about a new evolution, revolution, whatever you want to name it. It's a big game changer in the cancer industry, where you treat the patients based on the molecular profiling of the tumor using therapies that are targeted to that specific genes. And now, if you have breast cancer, you get different types of therapies. And that's my job. I obviously publish and do a lot of research and all that. Next. And I take care of babies sometimes. So this is conventional oncology. Thinking, talking, prescribing, practicing in a box. Meaning that, just like I explained, the conventional oncologist does not think outside the box. And if you fail the first and second and third line of therapies, that's what they do. They will refer you to the hospice. They will tell you that, unfortunately, whatever we had didn't work. There's clinical trials going on in Stanford and Mayo Clinic, and then you can go try them, but ultimately, the doors are closed. Now, we're going to talk why this happens. Why a cancer patient has to go through failure of other therapies. Why the cancer patient has to go through such a process that nothing works anymore. you remember what I told you? That chemotherapies sometimes make the cancer more aggressive and how that works. All right, so how many of you have heard of the term epigenetics or epigenes? None. Okay. So I have to give you a little bit background of what epigenetic means. How many of you have you heard of genes? Okay, I'm just joking. Everybody should know that. Okay, so genes, when they're mutated, when there is an abnormal gene translocation or deletion, when there's an abnormality in the chromosomal component of the genes, you have cancer. That's the concept of cancer and carcinogenesis, is that there is a mutation in the gene which causes cancer. Good, we knew that. Now, what happens is that this cancer gene that is mutated has to express itself. In other words, the gene, any gene, when you have a gene for black hair, right? It doesn't automatically become a black hair unless this gene transcribes a protein that is black and causes these melatonin, for example, in the cells. So there's a process of transcription from the gene to the proteins, right? And to the phenotype. So from genetics to the phenotype, there is a process involved. And that process is basically called expression of the genes, and what is influenced by is epigenetics. So there are components of outside the DNA components that control that gene's behavior or expression. The term, as you can see, is very old, and it was a philosophical terminology when it came. In other words, when you look at the old concept of epigenes, it was more a philosophical terminology. What you do, what you believe, your religion, all that can affect how you are, right? And it's true. Diet is true. It affects those genes' behavior, right? And so what is in the environment can change that gene's behavior. So I am an end result or a conclusion of environment and genes. So the end result of the effect between the environment and the gene expresses me. That's my phenotype, right? So for example, I go to the area that I have more sun exposure, or I go to the lower sun exposure, I get different colors in my skin. Right? So that's the environment, and I have to have certain genes to express that. So it's a combination of the environment and the genes. So a good example of it are caterpillars and butterfly. They have similar genes. They're identical. The genes are identical. But the phenotypes are different. Why? Because those genes, during the process of epigenetics, or the environmental influence, they behave differently, and you see different phenotypes. So going back to the cancer, a patient with cancer genes not necessarily has to have cancer unless there is an interaction of the environment with those genes that expresses as cancer. So it's a process that is reversible because they can turn back to each other, right? It's a reversible process, and it's also inherited. In other words, what happens to a patient with cancer is not just what he or she did wrong that caused cancer, but also it has to do with what the parents and the generations before did. So the parents smoked, and the child gets lung cancer. You got that? So these patients who have lung cancer and they never smoked, if you ask them this question, they will tell you that their parents did. And that's what I'm talking about. The expression of the genes is the process is inherited. Again, you see that what your mother ate can determine your lifetime outcome through epigenetic mechanisms. And it passes along different generations. So what you do now can affect your child's cancer risk. Okay? So we have a mutation process and we have an epigenetic process. The mutation process changes the genes, and that can cause cancer, but it also has to be some aberrancies in the epigenetics that let those bad genes behave It's like you have a bad child, but you're a good parent. The good parent tries to control the bad child, right? As long as there is a good parent, the bad child cannot cause problem. But guess what? When there is the good parent is gone, is traveling, the bad child then behaves badly. And that's the whole concept, is that if you have cancer, if you have cancer, it has been a combination of bad genes and no control over bad genes. So what we have done in the last few years is that we have developed a protocol that consists of variety of compounds, and majority of them are natural, as I said. They're non-toxic, and they basically don't hurt any normal cell. In fact, they increase the quality of life of the patient with cancer. What they do also is that they increase the effects of chemotherapy and radiation, and they make them less harmless. So how does that happen? Remember what I told you, that when a patient is diagnosed with cancer, they go to the doctor, and the doctor prescribes chemotherapy majority of the time. That chemotherapy itself can make that cancer more aggressive. And so you are automatically turning a patient with early stage to a later stage. What happens is that FDA looks at the trials, research trials, to approve a new drug. The criteria for FDA to approve a new drug is if a drug increases a disease-free survival or a progression-free survival. Do you mind if I use you as an example? So what is your name?
Denise.
Denise, okay. Let's see if Denise finds a lump in the breast, or a screening colonoscopy shows a mass, or somewhere she finds a lump. And she goes to the doctor, and the doctor refers to the oncologist. The oncologist does a biopsy, and the pathology shows that she has breast cancer, right? Again, they don't look at the niece tumor and say, okay, so she has this type of a breast cancer, we have to treat it accordingly. They just say, it's breast cancer, so this is the treatment for it, right? So the first problem is that the treatment is not customized. So if the niece and she, breast cancer, the treatment is the same. So that's wrong, because majority of these tumors, they are not responsive to the first and second line of therapy. They have different genetics. And in fact, the old concept that we have breast cancer is just one breast cancer is now outdated too, because now we know that one tumor, one lump of the tumor can have 10, 100, and even 1,000 types of tumors inside. So there is a heterogeneity of the tumor in every cancer. So it's breast cancers that she has. And the second problem is that they don't even look to see if the chemotherapy is beneficial or not, because she may very well have a type of a tumor that chemotherapy has no effect on. They don't test it. They don't know. It's just like you cough and you go to the doctor and they give you some antibiotics. Is this antibiotic going to work on that type of a bacteria that is causing pneumonia? No, we don't know that. We just use something that is broad spectrum. And what is the problem with the broad spectrum antibiotics? They cause resistance. The same is true here. So as much as we use these chemotherapies, they cause resistance in the other subtypes of the tumors that are inside that tumor that are not even sensitive to that chemotherapy. So we selectively give advantage to the resistant cell types. And what happens is that although the tumor shrinks and everybody is happy and FDA approves the drug, because remember what the FDA looks at, disease-free survival or progression-free survival. So as long as she has positive surrogates market, which is shrinkages of the tumor in the CT scan, the FDA drugs is approving the drug. And the oncologist is happy, and you go, and everybody's happy, which is almost every story of patients with cancer I've heard, is that they receive the therapy, tumor shrinks, everybody's happy, fooling ourselves that what is residual in her is not seen in the CT scan or PET scan. What is residual in her are those cancer stem cells that are undifferentiated, and so far as we speak today, there is no treatment for. So, remember, imagine that you have a colony of bees, and in this colony of bees, you have only one or two queen bees. Those are queen bees. Those are mother bees that are producing all these working bees. Working bees are that tumor. Those are daughter cells. But the mother cells are not in that tumor. The mother cells are in the bone marrow. They travel from bone marrow and they go to the breast or any area of damage because that's their responsibility. Stem cells are producing new cells to repair the area of damage. They're healers, right? And so they go to the breast because some inflammation is in the breast. They go to the colon if there's some inflammation over there. They go to the prostate because there's some inflammation over there. And they produce new cells. That's so far so good. What happens is that they get out of control. They're too good. They don't understand that the repair is done. They continue to produce new cells. Again, the intention is good. The cancer stem cells, I love them because they think that the area of damage needs repair. They don't want to produce new cells to kill you. They're just doing that for a good faith and good reason. The only thing that is caused them to go out of control is the epigenetics, is the same aberrancy that has happened that basically doesn't control the gene expression on time. So they continue to produce new cells. So there is a problem with genetic expression in the cancer stem cell that causes those cancer stem cells to become cancer stem cells. In other words, translate from normal stem cell to cancer stem cell and become immortal and produce new cells all the time. But it's an aberrancy that started back when her mom ate something wrong. You got that? So it's not Denny's fault. Her parents did something wrong, were exposed to something, and that caused epigenetic aberration in the stem cells of the offspring. Okay? And that's why as much as we use chemotherapy, we can just kill those working bees. The mother queen bees are not touched by chemotherapy, are not touched, the stem cells are completely undifferentiated. So they don't even absorb chemotherapy or any drug. And they're not killed by radiation or surgery either, because they're not even in the location of the tumor. So because of that, the cancer comes back. And that's 90% of the time the story that I hear. The patient goes, everybody's happy because the FDA has approved the drug that works only for a few months. It kills and destroys all the daughter cells. Everybody's happy. And we fool ourselves because we have the stem cells over there that we intentionally or unintentionally made it angry. Because as soon as you destroy these daughter cells, as soon as you get rid of these working bees, technically speaking, these stem cells come out of this rest phase or G0 and they start to produce new cells. Okay, any questions so far? Does that make sense? Okay, good. You see, I'm using my math brain. It's not biology. If you talk about, when you leave this room today, you will know more than many doctors. Majority of the oncologists are not familiar with what I'm talking about. Some of them do, and those are the ones that are in the field of research. See, 90% of what I'm talking about is not alternative medicine. I'm not talking about natural compounds yet. I'm just talking about conventional medicine, and every seminar that I go to is the seminar. I don't even go to the alternative medicine seminars because I've already taught everybody. And so now I'm only going to the conventional research in epigenetic seminars that I just came from Spain. I give a lecture over there in Barcelona to all these epigenetic researchers because that's the field that the medicine is going in cancer. Every pharmaceutical company that I'm aware of, they have the prospect for the next 10 years just focused on epigenetics. And the drugs that they are producing, and I explain a little bit because I know these scientists very well personally, and I know the drugs that they're working on. The drugs that are working on the epigenetics, so they know what's the problem, right? They have to go after stem cells, they have to fix what the aberration was, but they can't make a drug. You know why? So I spoke with this French scientist. His name is Christian, very knowledgeable guy. He said, this is what we did. In the lab, in the rats, we found a drug, a target on the cancer stem cell that we can target and we can knock off these stem cells' activity. Well, that's great because so far we didn't have anything for stem cells, right? Now we found it. But guess what? It makes it goes to the stem cells and goes to those targets that are involved in carcinogenesis, and it knocks them out. But those targets are also present and involved in normal stem cell. So what happens, yes, the cancer is not produced anymore, but these rats all die. Because these stem cells are also have to be there to repair the area of damage in a normal person. So how can you just go after? So that's where natural therapies come to the place. Why? Because natural compounds are the only things that over millions of years our body has been adapted to so delicately that they can just turn the volume down on these genes without knocking them down. You got that? So it has to be a very tuned balance on lowering their expression instead of knocking them down. And every drug that they have found, they're unselective. So not only they knock out the bad genes, but they also knock out the good genes because they're also involved in epigenetics. Epigenetics doesn't mean that we just have to get diseased by it. It's involved in it's a dynamic process of every DNA gene expression. So what happens is that now you turn down all these genes, and once in a while you get success with lowering the cancer growth. But you also cause mutations in good genes, and it also causes other types of cancer because now you're going unselectively. Now natural therapies come to the place. Now, so you see that so far I have just put my feet in the steps of researchers in conventional medicine. Now I turn back. Now I turn back. So now I know what they're doing. I know what's their fault. Now I have to find another solution for it. And that's called MTET. So what is MTET before this? Can you go before? Okay, so MTET, it stands for Multi-Targeted Modified Epigenetic Therapy. Targeted epigenetic therapy. Multimolecular targeted epigenetic therapy. What does it mean? It has multi-targets. So instead of chemotherapy, that even targeted therapies, you've heard about these advertisements about new targeted, oh, there's a novel therapy for one type of cancer, and it targets BRAF, for example, in melanoma. Okay, there's one target. Our therapy, because these natural compounds, they have variety of targets. One compound that I use has 150 targets. That's why it works. Because if you just have one target, you can block that. But we are just, again, fooling ourselves because there are feedback loops between the mother molecule and the daughter molecule. So you look at the pathway, and you see that, okay, I shut this down, but there's a feedback loop that goes up, and it tells the mother molecule to produce more. So unless what you're using is multi-targeted, pleiotropic, both in horizontal and vertical pathways, you're still fooling yourself because you leave what we call cancer got smarter. You leave some targets that they will overexpress. It just takes time. And we all know that, for example, for stage 4 disease, using chemotherapy is just a waste of time because they call it palliative chemotherapy. The oncologist always tells you, okay, we have some treatment that may help you. They don't open the discussion. How is it going to help me? How is that going to help me? Is it just going to give me 3 months? Is that help? And 40% toxicity? In fact, some of these FDA drugs that FDA approved recently, one of them was for colon cancer, and it worked on 0.6% of patients. So you have 99.4% failure. And that 0.6% of patients only had 9 additional days. And they got it approved through expedited, accelerated approval process. And then it came to the market as a novel therapy, multi-million-dollar compound. And it had 60% toxicity. You know, I was in FDA myself about 2 months ago. And it was a workshop. So I went there. and I met with the chief of the drug division department. And I raised my hand because he was talking about safety, and we're so strict, and they come there with general outfit, and they're so proud of themselves, and they give. And then I said, well, I have a question. You talk about all these safeties. What about these drugs that you're approving? They're not safe. They don't even work. And you know what he said? Because everybody was looking at me. He said, you're right. And we know that. And I'm telling everybody in my department, do not approve these toxic placebos. Okay, so we talked about carcinogenesis. Obviously, the first initial step of cancer development is called carcinogenesis, and it starts with cancer stem cells, just like I told you. So we know that our therapy works, and I have proven science to show that my therapy differentiates the cancer stem cells, and it normalizes their behavior, and it controls the cancer stem cells. So it's involved in carcinogenesis. And that's why I proposed to Parker, and you guys, by the way, are very lucky, because you have a very, very intelligent, kind, and people who look after you as your leaders. And they're the ones who pay for the cost of your therapy when you come to see me. Otherwise, if somebody was not working on Parker, and I have some of those right now in my clinic, the treatment is not cheap, and they have to pay cash. But that's another proof for the effectiveness of my therapy, is that we don't charge insurance. So what does that mean? The oncologists charge insurance, right? If the treatment works, or if the patient dies, they get their money. So there's no incentive. In fact, there is incentive to give more chemotherapies even if they don't work. So the protocol is, again, MTET. We talked about carcinogenesis. It controls the cancer development. And what I proposed to Parker was that I can reduce the cancer development, the diagnosis of cancer, the initiation of cancer. I can reduce that risk for about 60%, meaning that amongst you, whoever have cancer, obviously you're covered, you can come to see me, or we can treat you. Whoever doesn't have cancer, we can reduce their chance of cancer for about 60%. And just calculating that in how much is the cost of a patient with cancer in average, we have about $1 to $1.4 million in average from stage 1 to 4 that the insurance company, Parker, Medicare, whoever is the patient itself, they have to pay. The average cost of a patient with cancer is about $1 to $1.4 million from stage 1 to 4. When you go to the stage 4, it's more than $3 to $4 million in average. And it doesn't work. And they have to pay for the disability of the employees too, because they can't go to work, because they're toxic. The treatment is toxic. The treatment makes you so toxic that you wish to die. It gets to the point that you go to the doctor and say, doctor, I think I'm done. And then guess what? They're always ready for that moment because they know that it will come. They know that you will get to the point that you will be exhausted and you ask for death. Because at least at that point, you don't get the toxicity of chemo anymore. They stop, right? MTET works on tendency of a tumor to spread. Metastatic tendency of a tumor to spread. How does that work? Again, going back to Denise. She was diagnosed with a tumor, a lump in her breast, right? She goes to the oncologist. They give chemotherapy. The tumor shrinks. Everybody's happy. Okay? What they don't check is markers for cancer's spread. Because they know that if it's up, they can't do anything about it. They know that it will be up with chemo. One of the things that chemotherapy is notorious for is that it increases the cancer's tendency to spread. I have patients with breast cancer, for example, that I just mentioned, that as soon as they get the first chemo, it metastasizes. It shrinks, but then you have bone mets. What kills the patient was not the tumor beginning. Now you have a stage 4 disease. Remember what I told you. We make the stage 1 a stage 4 by treating it. That is incurable. Now, whatever I put to chemotherapy-wise is not going to work, right? So this therapy doesn't do that. In fact, it lowers the tendency of the tumor to spread. So when you combine it with chemotherapy, for example, you don't see that tendency of the tumor recurrence. You don't see that tendency of the tumor to spread. And it improves the response. Next slide. So this is an example. We talked about breast cancer. So this is a breast cell line, and I have tested from melanoma to sarcoma to lung, pancreatic cancer, brain cancer, you name it. This is an example. Breast cancer, which was treated with nitrogen mustard. We cultured these cancer cell lines, and this is not my lab. It's an oncology lab in Canada. They cultured these cancer cell lines, and I wanted to see how my treatment works because I saw the results clinically. Now I wanted to go back and do research on it because I wanted to know how it works. I know it works because I see the patients that they respond, but how does it work? Okay, so this is, we talked about combination with chemotherapy and improving the response. This is nitrogen mustard by itself. This is how much it works. This is the curve of response. So it shows kinetic units of apoptosis. So the higher, the better. The higher, the more cancer cells are dead. This is chemo. This is in combination with my therapy. It goes up from 3 to 36. More than 10-fold increase in efficacy. The director of the lab called me when they got the results. I had no idea. I just sent them the compounds and I said, well, this is what I want you to do. And they tested it all across the board. We chose every chemotherapy under the sky. And we tested this with all of them. He said, we have never seen this. Never. And this is the oncology lab that FDA in Canada uses to approve drugs over there. He said, I have never seen a drug that effective. Well, translate that to the human being. Patient goes, no oncologist has any clue of what these are, right? They start the Cytoxan, which is nitrogen mustard derivative, right? They give Cytoxan or doxorubicin, or those are the first-line therapy for breast cancer. Patient doesn't respond. Obviously, he's not going to respond. Obviously. And this just is on a cell, let alone the tendency of the resistance, the tendency of the cancer to spread, the immune suppression, the toxicity that the patient goes through, all that. The tumor doesn't respond. What are we doing? Toxic placebos. Next one. Some cases. So far, do you have any questions? So far, so good? Okay. So this was a Parker patient, I believe, yes. 54-year-old. She had 4 types of tumor. 4 types of cancer. Thyroid, breast, appendiceal and colon, and kidney cancer. What else can you wish for? Remember what I told you. It is not the location of the tumor. All these cancers would have been treated differently by an oncologist. Oh, you have kidney cancer, this is the therapy. You have breast cancer, this is the therapy. Well, they are originated from the same cancer stem cell, from the same epigenetic aberrancy, from the same problem that she had in the genes, showing in different places. Right? Make sense? So she was treated with hormonal therapies, she had mastectomy, she went through conventional therapies, first recurrence, second recurrence. Then she came to see me. Before she came to see me, story is funny. She goes to the oncologist and sad. And her oncologist in Cleveland, this is what she said. You're fine. We did a CT scan on you. You have some lesions, but those are probably lymph nodes. It seems okay. I don't worry. Just continue what you're doing. You're doing fine. She would have been dead like that if she would have listened to that oncologist. She comes to see me. At that time, I had an office in Fresno. Now I have one in Newport Beach, very close to you guys. And I do a PET scan. Obviously, PET scan is the best way to measure the activity of the tumor. So I'll share with you the picture so you see what I'm talking about. but the tumor activity, meaning that how it's growing, is measurable, versus CT scan just shows size of the tumor. So, two examples. If you have a tumor in breast this size, but it's very low active, or if you have a tumor this size, very small, but very active, which one is worse? Small one. Because that's the one that's going to spread and go to the other places and kill the patient. The big tumor, the size, doesn't really matter. Just like I said, the tumor that is smaller is more dangerous because it can be more active and it can spread very quickly. So how do you measure response to the chemotherapy looking at the CT scan? So the same story. They told her, you're fine, go home. So she came next. And this is the PET scan that I did, and this is what we found. Presence of metastatic lesions in all levels. Thorax, axillary, cervical, chains, lymph nodes, thyroid. The activity was up to 20. This SUV activity, as I told you, is a measurable scale. So you can measure the activity of the tumor by numbers. So from 1 to the highest I've ever seen is 25, 26. Hers was 20. You'll see that it shines, the lighter it is, it's more active. It's like a light spot. It shines like sun. And all tumor markers are out of control. So we started the treatment. One of the things about my treatment is that, first of all, somebody asked what's the method, what's the route of administration, is IV therapy. Everything is injectable. So what we do is that we extract special compounds from the nutrients and we make it intravenously administrable. And what it does is that it picks up the high serum level in the blood that works. So for example, if you take all these nutrients orally, or if you take supplements, do they work? No, because there's a gut barrier that doesn't let these nutrients to be absorbed. So I had studied two groups of patients, for example. One group of patients with the best supplements, they took it religiously, and the other group of patients didn't take anything. The results were the same. And I can show you that what I use intravenously is not absorbable at all if you take it orally. They talk about curcumin, for example. If you take curcumin or turmeric, does it absorb? No. If it absorbs, it's, even in the liposomal form, it's so small that it doesn't work on cancer. You have to get to that serum therapeutic level to be able to get anti-neoplastic effect. And so she did the therapy, and what I usually do is that if a patient with a new diagnosis comes, this is what I tell them: give me 2 weeks. Just 2 weeks. I give them treatment every day, and after 2 weeks, I remeasure every marker. And to this point, I have not seen the first patient that has not responded in one way or the other. So we measured all these markers, we evaluated after receiving daily therapies. All these markers dropped. PET scan confirmed positive response to the therapy. You see the PET scan in a second. Next. Again, significant positive responses. We did like 3 PET scans every 2 months. All of them shrink. Activity shut down. The radiologist, this guy from Val Metabolic Imaging, by the way, I didn't prepare these image sliders that you see. He called me. I've never seen this guy. Never knew what's his name. But he was a radiologist who was reading these scans. So he calls me and he said, "What are you doing?" "I want to see you." So he comes to the clinic. We got to know each other, and he said, "Oh, I've never seen these. These people are very tough patients, very advanced disease. They have failed all these therapies. How do you get these results?" And so I gave him a little lecture just like today. And so he voluntarily, without me paying him a penny, got all these scans out, and you'll see in a minute how they compare the pre and post therapy. And he said, "You know, I'm coming to anywhere you want. I'm going to come to Parker." He came to Parker in Cleveland. He said, "I'm going to come to the FDA. I'm going to come to the NCI. I'm tired of reading these PET scans by oncologists and say, progression of disease, patient's not responding. I'm tired of that. I want to see a patient getting better." Next. This is the patient I talked about. You see, these lesions are cancer, white spots, right? This is bladder, urine, normal physiological activity, and the brain also. So how many of you have cancer or have relatives with cancer? Many. So you know what I'm talking about. PET scan is the only way that you can assess cancer. Forget about CT scan. And if you had PET scan, if you had tried PET scan, you see that they give you an injection of labeled fructose, radioactive fructose, that basically is sugar. And as you know, cancer uses sugar to grow. So Warburg effect, since 1935, we know that. The cancer absorbs sugar. That's how this fructose gets to the cancer, and it lights up because it's labeled. So the machine is just like a CT scan. The only difference is that there is an injection of radio-labeled fructose as an IV contrast. Obviously, brain uses sugar, so it goes to the brain too, it lights up, but that's normal. Anything else besides bladder, urine, and brain is abnormal. So this is abnormal. Next. Post-therapy, nothing. This is pre, this is post. This patient. All these metabolic activity of the tumor, these are high lymphadenopathies, very big in this case. You'll see in the next slide. They completely shut down. You see that? These are very big tumors. This is a transaxial section. It's just like they cut me from here. These are lungs. You see air is black, right? Bones are white. And anything like this is cancer. Very active. They tell you it's SUV activity of 20, just like sun is shining there. You see that? And the oncologist was telling her, oh, you're fine. You have nothing to worry about. Just hang in there. We're going to do another CT scan. In the CT scan, it doesn't show anything. Look at the CT. That's CT. The CT scan doesn't show anything abnormal. Pre-treatment, post-therapy. What do you think?
Wow.
Yeah. And this is general rule than exception. Every patient should get this result. That's why when a patient comes, I tell them, give me 2 weeks, and I'll prove to you that this therapy is superior to any therapy available and existing in this country or the other. Next one. So you see the activities came down. Growth factors, the same thing, talking about carcinogenesis and cancer stem cells. This FGF2, a fibroblast growth factor 2, is there's a pathway from HIF down to Notch1, a snail slug went, and FGF is, I don't want to make it complicated, but this has to do with the cancer stem cell activity. Next one. Next one. Okay, case 2. This lady heard me speaking in Dallas about 2 years ago in an IPT conference for those chemotherapy with insulin. And I'll talk about that if you have questions after the session. So one of the things that I told you, I went through all this research, I went through all these conventional seminars at MIT, Harvard Cancer Stem Cell, all these. And then I also did the same for alternative therapies. So I went through all these alternative conventions and became a master in them. But 10% of each has a role. And I found that 10% of each, and I combined them. So this case was a lady who had breast cancer again and had failed 6 chemotherapies that was administered through IPT. Every time they gave her chemotherapy, it was worse. Another chemotherapy, it was worse. Another chemotherapy, it was worse. I don't know how sick somebody could get better before they get better. They don't stop. This doesn't work, let me try another one. That didn't work, let me try this one. Anyways, she tried 6 chemotherapies, and then every time she got worse, finally she said, okay, I'm going to go to California. So she came to see me. On the first day she came, she couldn't walk because she had the big pedal edema, swollen legs. She couldn't breathe. You'll see in the scan, she had 3 liters of malignant pleural effusion in her lung that we had to drain every week, and it was filled up again. Every week, 3 liters. So we send that fluid, we draw the fluid, we send it to Dr. Weisenthal here in Orange County, who does the chemosensitivity testing for a long time. I used to be a friend and used to work with him. And he did a test on chemosensitivity testing, that's what it's called. And that showed that there's no chemotherapy that works on her type of cancer. No chemotherapy works. She was it. There was no option. If you go to the website, by the way, write the website, www.allcancercare.com, A-L-L, cancercare.com. You'll see her testimonials. Allcancercare.com. So we started the therapy, and immediately, I don't have time, so I go quickly. Immediately, she responded. This 3-liter fluid, you'll see this, the next scan, was completely gone. After a few weeks, nothing came out, dropped gradually, nothing. We did a thoracentesis, sent it for pathology. There was complete pathological response. They could not find a single cancer cell. This has never been seen. You see the mass is occupying the entire breast. She refused surgery. Chemotherapy didn't work. Hormonal therapy didn't work. This is the size of a mass, pre, post. It's like you removed it. It's dead. Next one. Look at that. And the fluid. This is the fluid in the lung. Compress the lung. As you see, the air is black. This is the fluid. Compress the lung completely. Next, post-therapy. This is miracle. Prostate cancer, same story. Completely gone, complete response, complete remission. I don't know what to name it. I mean, these are just, look at this. Physiological activity? It's like he never had cancer? Next one. Look at this cancer in the bone. Post. Normal. Normal. This is a marker called CTC, or circulatory tumor cell. It tells you how long you're going to live. How long you're going to live. Hers was 24. Anything more than 5, you're going to live for 4 months. Overall survival of 4 months. Anything more than 5, and hers is 24. Look at the date. April 4th, 2011. Next one. April 25, 0. 3 weeks later, it's gone. Next. PET scan normal. Next. 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 Malignant melanoma. The worst type of tumor to treat. There's no conventional treatment for it. All these are malignant melanoma. Pre-treatment. This is a Monday. I treated her every day for 1 week. Look at the next one. Cancer's gone.